Okay, it's 9:15, so I think we'll begin, Joe, if that's all right.
Okay.
Good morning, everybody, and welcome to the May 2021 West Suffolk Clinical Commissioning Group Board. Do we have apologies, Joe?
I've received apologies from Richard Watson, and I believe Amanda is going to have to leave it.
I understand, yes. Okay, thank you. Any declarations of interest? Okay, thank you. The minutes of the last meeting. Those of you who've read them, are there any comments for accuracy?
No, I'm happy with them, Christopher.
Okay, thank you very much. I've got 2 sage nods, so that's great. Thank you. Any matters arising? Not otherwise covered on the agenda? The action log.
Shall I take us through that?
Please do, thank you.
So the first one was around the maturity matrix that we're working through with our integrated neighbourhood teams, and I'm happy to say in some ways that the team have asked to prioritise their frontline services at the moment, so they are completing it, and Sandy Robertson supporting them to work through it for each of the localities. But equally, they are needing to, with the increase in activity, they are needing to prioritise their frontline activity. So I would suggest that I bring that back to our next board conversation, because it should be done by then. The work is happening, but they couldn't complete it by May. And then, Paul, do you have an update on cancer?
Yes, I will do so. So apology if you can just bear with me, because these questions often seem quite straightforward, but they're not. So I'll just spend literally 30 seconds explaining what I've looked at. So the first thing to say is there was a working party established mid-April to look exactly at that question, whether or not we'd seen some increase in emergency admissions. I'm still finding the exact conclusion of the meeting, but essentially there was insufficient data to demonstrate yes or no, and partly for the reason for that is that the national data only goes up to Q2 2020. The other point to make around that is that the data is a proxy data, it's a formula, it's not an actual direct measurement of emergency admissions, which rather complicate matters. What it did show, though, in Q2 is that there was an increase in emergency admission around cancer in and around Q2. I then went and looked at the data that SNF do routinely capture. What that data shows is that there has been a steady decrease in emergency cancer admission right from 2018, but around Q2 there was a peak in admissions, but it preceded a decrease at around March time, which when we went to lockdown. So again, really difficult to see whether there was actually an increase. What I can say, though, is that the data appears to be then showing a rapid deceleration back to sort of the norm we would expect. When looking at West Suffolk, which is the crux of the data, again, data is not captured in that way. So what we did was to look at proxy measures, and we looked at 3 things: the total number of 2 weeks referrals, the total number of actual cancer referrals, and the point to make that there is no divergence between those 2 figures, which is an important point, and doesn't seem to demonstrate any increase in cancer diagnosis. What it does show, though, is a similar sort of trend around Q2 2020. So clearly, the conclusion I can reach from that, and please, it is a personal conclusion rather than a definite conclusion, is the fact clearly when we went to lockdown, there seemed to be a reduction in activity captured by an increase in admission. We seem to have settled down ever since, which would fit in with our understanding what the action that we took. In order to make sure that we don't lose that point, I've asked the cancer board to discuss this, just to make sure that there is not any other line of conversation we need to have. So my general conclusion, it doesn't appear right now that we have an increase in emergency admissions, but again, that needs to be tested. I hope that helps as an answer.
Andy, do you want to add something? Thank you, Paul.
Yeah, thank you for that, Paul. I think on the whole, before the pandemic, cancer emergency admissions was dropping, and in West Suffolk it was about 16 to 17% of all cancer referrals into the system were emergency admissions, having been up at around 20% 5 years ago. So they have been coming down. I think it's difficult to say quite at the moment, but I agree with Paul. The only thing I would say is that with regards to tumour sites that we are concerned about, prostate is the one where we don't seem to see so many numbers coming through into the system. So I think there are prostate patients still out there who have not come through. We know from information provided locally and by the Cancer Alliance, there are about a third. The number of prostate patients coming through are down by about a third. So they could come into the system later. Thank you.
Thank you. Okay, I think we've done, and there's the primary care bit, Kate.
So just very quickly, my lead for this had to take leave unexpectedly. So there is a paper that's being pulled together, but it's stuck at the moment. So I would like to ask for permission to bring that back to the next board meeting, if that's okay.
Permission granted, yes, certainly.
Thank you very much.
Okay, thank you very much. Right, on we go to a general update, please, Ed.
Thank you. We're going to have a film as part of this update, which I'm promised is inspirational, so I'm looking forward to that. But before we get into it, just want to say how pleased I am to see all the mental health work on the agenda come to fruition today, and all the hard work that's taken place over many months by many people is greatly appreciated. So really very welcome to have our patient story and those papers on the agenda. Just three or four updates from me is one, we're continuing to make very strong progress on our vaccination programme. Despite all the challenges around it, 50% of our adult population in West Suffolk have had two doses. We've reached 1 million jabs on Friday as an ICS, and we do have pockets of inequalities that we're focusing on in terms of some communities, and in particular some of the younger age groups not coming forward. So still many challenges to go, and we've got quite a differential in terms of uptake between men and women, with a greater proportion of women coming forward for jabs rather than men. So we've also got to think about how we engage the males of the species too. But overall, some very strong progress. Thank you to everyone's involvement in it. The second equally big priority is obviously recovering our services, and we've become a national accelerator system. I think there are 12 systems nationally that are being supported with additional funding, in particular to recover elective waiting lists. That's very important for us in West Suffolk, because we've got challenges on the current hospital estate, which means we've got reduced theatre capacity. So having more resource to work through our waiting list is absolutely crucial for us. So really grateful to the national support. We've formally launched an integrated care academy in Suffolk this week, and there's a foundation week, which I think over 1,000 people have signed up to various events. So do look online if you want to join any of the developmental sessions. I think Kate is running one too, which we're all looking forward to. So thank you, Kate, for stepping forward. And it's going to be a great way of building on all the collaboration and learning that we've got locally. And then finally, it's noteworthy to look at the headline news in Suffolk yesterday around the country around access to dentistry, which is a very big issue locally, regionally, nationally. Whilst we're not the commissioners of NHS dental services, it's likely that we will be in the future. So for lots of reasons, I think we need to take a closer interest in this area, because it's a big issue for our population that we need to drive some improvements on. So those would be some of the updates from my perspective, and we'll launch the film in a second, but Kate wants to come in.
Sorry, no, not to add to any of that, which is all brilliant. I'm just reflecting on the time being 9:25, and Lulu has got a firm commitment at 10. I wonder if we need to save our having asked for it to be shown, our video for slightly later in the agenda, so that we can make sure that we don't cut the mental health discussion short. Would that be acceptable, Christopher?
Yes. Is that the same video you're referring to before?
Yeah, I've
Okay,
only
so there's
got one video.
Yeah, sure. Okay, well, we'd already more or less agreed that, hadn't we? Okay, thank you. Thank you. Okay, right. In which case, thank you very much, Ed. Does anybody have any questions for Ed? Okay, in which case, let us go on to patient story.
I'll set the scene if that's okay, Christopher, just in terms of the mental health discussion this morning. We're delighted to be joined by Carl Coughlin and Sasha Campbell, users with experience, to talk to us about gaps in services in Suffolk for personality disorder. We'll then move, because of Lulu's diary, straight into a conversation about the business case for personality disorder that's been worked up and co-produced, and get that conversation hopefully done and agreed. And then we've got three other items: an eating disorder phase 1 business case with Sarah Cross from NSFT to talk us through. I'll give a brief mental health investment update, and then John Harris will be joining us to talk about conversations and work with the ambulance service as far as mental health is concerned. So without further ado, again, delighted to have Sasha and Carl with us this morning. If I could pass, I think, Sasha, if we're going to have the same running order, guys, as we had yesterday. Sasha, over to you. Thank you.
Thank you. Before I begin, I'd really quickly like to say that being a part of the personality disorder and complex needs pathway has been a complete and utter privilege. Before joining the team, I thought that I knew what co-production was, but it turns out I was totally wrong. Never before have I seen trained professionals and service users working together so equally, so genuinely, or so excitedly. And never before have I been prouder to be part of a piece of work or more hopeful for the future of our mental health services. And I really don't believe that these co-occurrences are at all coincidental. Now I just need to try and figure out how to communicate to all of you the transformative power of the pathway. And I reckon that the best way for me to do that is to share a bit of my story and stop to reflect on how my journey could have been made quicker, easier, and significantly less painful had the pathway existed when I first became unwell. So I'm going to rewind to 14-year-old Sash. 14-year-old Sash, who, despite having a wonderful family, incredible friends, and an abundance of hobbies, was thoroughly miserable. She'd been self-harming already for 2 years, secretly longing for help, but feeling too scared to seek it. And when she finally did gain the courage to ask for help, she was denied it. Apparently, Sash was not ill enough for CAMHS, but was too risky for wellbeing services. In fact, I was actually rejected from CAMHS 4 times that year. The words "not ill enough" ever present in my mind. Not ill enough? How humiliating. I'd have to do better. It was only at 15, after a near-fatal suicide attempt, that CAMHS finally accepted my referral and shoved it on the 9-month waiting list, during which time I deteriorated rapidly and was sectioned to a CAMHS hospital against my will. This need not have been the case, and if the pathway had existed when I first made contact with mental health services, I really don't think that it would have been, because the personality disorder pathway knows that when someone asks for help, the only correct answer is yes. And at 14, I was desperate for help. I really wanted to stop self-harming. It interfered with my life as a competitive dancer. It drove me away from the people I loved, but above all, it really scared me. I wanted to stop, but I just didn't know how. I needed a bit of help, someone to listen, someone to care, someone to advise. And I wasn't asking for a care coordinator or family therapy or an intensive therapy course, just a few coping skills and a few kind words. And I know that the personality disorder and complex needs pathway provides different levels of care suitable for all needs, regardless of risk. Like, they recognise that ill enough doesn't exist, that people don't matter because they suffer, and that risk just is not a measure of illness. If the pathway had been there to support teenage me, I'd have known those things too, and my desire to recover would not have been replaced by a need to become sicker. And so much pain, loss and trauma would have been avoided as a result. Most of this trauma and loss came from my inpatient admission, an admission that, as I previously stressed, was completely avoidable. I spent nearly 2 years locked up, far away from the family and friends who inspired me to get better. 2 years without school, 2 years without fresh air, 1 year without therapy, 1 year without medication, and nearly every minute of it traumatic. I saw and experienced things that no young person, well, actually no person, should have to see. I found friends, blue-faced, barely breathing, heard shrieks, so animalistic and so raw that I can never unhear them. I've been stripped naked, transported in cages, handcuffed to nurses, brutally injected, sexually abused, aggressively tubed. Once I was locked in a seclusion room for weeks and fed through a hatch in the door, left in a bare room, distressed, alone, and only a child. But the worst part of it is that these things don't ever properly leave you. I still feel sick each time a song or a scent reminds me of hospital, still wonder which of my friends is dying every time that an alarm sounds, and I still wish that I'd been sicker than I was. I also grieve for my younger self, the self who had her childhood stolen so violently, who missed A-levels, prom, school trips, family holidays, first words, last words. I can't really articulate the profoundness of these losses, of the pain that I feel each time my gorgeous little brother says that he doesn't miss me when I'm at uni because he had to get used to not having me around. The pain that I feel every time I'm unable to join in with my peers in a nostalgic conversation about the teenage years. The pain that I feel every time I receive a phone call to say that another of my friends has passed away. And why do I tell you all of this? Because it did not need to happen. And with the personality disorder and complex needs pathway, it absolutely won't. The pathway believes in short, meaningful admissions. People won't be tossed into hospitals and left there indefinitely, left there until every millimetre of hope has been drained from their body. Instead, all admissions will have a clear purpose and goal. The day a patient arrives on the ward will be the day that they begin working towards discharge. And as a direct consequence, so much pain, trauma and loss will be avoided. The benefits of the pathway simply cannot be overestimated. Before I finish, I'd also like to stress that despite all of this pain, I also met some of the most amazing people on my journey, both patients and staff. There are nurses, healthcare assistants, therapists, doctors, cooks and cleaners whose extraordinary words will stay with me forever. These staff members want an exceptional service every bit as much as we service users do, and I think that the PD pathway is evidence of this. On that note, I would love to pass you over to Father Carl, who is the single most brilliant person mental health services introduced me to.
Thank you.
Sasha. You know what, I've been working with you here and it never ceases to capture my heart when I hear of your journey. And yeah, really well put. Nobody could have put it better. So yeah, I'm Carl and I'm Sasha's somewhat older counterpart, just in case anybody hasn't noticed. Only by a few decades, I think, Sasha, isn't it?
That's about right.
Yeah. Anyone who knows me, and I'm going to say again, Eugene knows this well, I do not like telling my story. It's something I've always struggled with, other than when I was in therapy. But this pathway deserves a little insight into it. So I became unwell when I was 11 years of age due to constant exposure to extreme life-threatening traumas, or ACEs as they're called, which is adverse childhood experiences. I think the recommendation is maximum 4 in a childhood. I was probably having 1 every hour of every day throughout my childhood. These experiences proved devastating in adulthood. I ended up losing my home, my business, my family, which all of those I've regained to some extent. But the one thing I never will regain is the lost years I had. And I remember me and Sasha worked it out once that on average, I reckon I've lost 3 months for every year past the age of 11. And that totals to 12 years of my life that has disappeared. You know, so maybe that's why I look 50 rather than 60. Maybe I'll just save 10 years somewhere. I don't know. But that's the sort of thing you can't recapture. It's an impossibility. And this is where this pathway becomes really important, because it uses things like needs typing, so addressing needs rather than diagnosis. So people won't need to lose all them years. They can access treatment much quicker. And what it does is destroy the cultural belief that personality disorder is finite, or not real, or is an attention-seeking tool, whatever terminologies have been used in the long distant past, which thankfully I'm glad to see has changed a lot in our trust. When I got diagnosed just over 10 years ago, it came to me that I couldn't accept that. I wouldn't accept it. There must be more to my life than this diagnosis. So I started working hard, and Eugene will know this, about trying to get something sorted out around personality disorder. And so you can imagine my delight 4.5 years ago when I met Lulu Preston, and we began working together on this PD pathway. And we did it without money, did it in our lunch times and our days off. There simply was no money for it at that time. But undeterred, me and Lulu worked really hard at putting the pathway together, making sure it was fully co-produced from day one, which of course it was. And we roadshowed it, and we've had a lot of people sort of tell us, no, they don't want it. And that includes some service users. They don't believe this pathway can ever happen. But when we roadshowed it, we listened, we looked at where all the best practice was. We realised that staff didn't have the correct tools in their kit, so they wasn't upskilled by training. We needed to create something like needs typing, so we could address needs as and when they appear, rather than wait for diagnosis. So for the people like myself and Sasha, if this was now that we was presenting, it would mean that we'd have faster access to therapies that include dialectical behavioural therapy, etc. And that's not easy for me to say, and a host of other different therapies. For younger generations coming through, it will mean, quite simply, they won't lose 12 years of their lives to a personality disorder where they didn't need to. But more equally important, what's in it for our trust and our CCGs? Well, I think that we will see greater staff morale. I think CCGs can be very proud of themselves for funding us and believing in us. And I think all in all, the most important thing is we have something to celebrate here. Thanks very much.
Thank you.
Sorry, Chris, I was just going to say, Carl and Sasha, thank you for your courage and your empathy and telling your story so beautifully. We really are fortunate and lucky to have you here with us as many times as we talk and hear your really important story. Thank you ever so much. I was just going to tee up Christopher, if I may, Lulu, who, as Carl said, has driven this piece of work to get us to this point today in terms of working with Sasha and Carl and others to get the business case that's on the agenda. So if we could go straight to Lulu to set out the business case and what we're asking off the board, please, Lulu.
Thank you, Eugene. And again, Carl and Sasha, thank you. It's always very difficult and slightly awkward to follow what you've just provided with something a bit more businessy and operational, but that is my job, so I will try and do it. As Carl was saying, this work has been ongoing for 4.5 years. What we're presenting today is not just a model of care, not just a model of treatment, but we've also got proof of concept because we've begun implementing elements of the pathway in Norwich already. That implementation began about 2 years ago now. So we have some local evidence demonstrating that the dialectical behaviour therapy that Carl spoke about is having significant effect in terms of reduction of suicidality, reduction of self-harm, reduction of hospital stays, reduction of distress and pain. We've also upskilled our workforce and we've changed the face of it. So we've increased recruitment into peer support working posts, nursing and psychological posts to deliver that psychological therapy. We're modelling that or using that model to suggest rollout across Suffolk so that we're going to change our workforce, going to make it more tailor-met to the needs of people with personality disorder. As Carl noticed, we're introducing a needs typing framework which doesn't displace or replace diagnosis, it complements it. What needs typing allows us to do is, despite somebody's diagnosis, we can still attend to the fluctuating need that we know is such a strong feature of the experience of people with personality disorder type needs. Also, it means, speaking to Sasha's point, that we don't need people to get ill enough for long enough before we actually meet that need. So needs typing allows a more dimensional, continuum-based understanding of a trajectory of distress. So we will be skilling up people in primary care in the needs typing screening tool. We will be offering co-produced and co-delivered psychological treatments in primary care. We've begun already to partner with voluntary care sector agencies to skill them up to support and also provide more evidence-based treatments, as well as refining our offer and in delivering more specialised treatment within secondary mental health care. So we're not talking about a discrete ivory tower service that runs the risk of requiring people to be ill enough to enter. We are talking about improving our current provision, elaborating it, diversifying it, and providing that intervention that's evidence-based right at the GP doorway and into the voluntary care system as well. Why do we think this will work? Because, as we've said, it's worked in Norwich already. Why do we think it would work there? Because the model is a summary of what our local stakeholders, staff, service users, carers, and the wider system have said they need us to provide, as well as drawing on the research evidence, the practice-based evidence sites from hospitals up and down the country who we've contacted, and they've been very open and sharing of what they've done. It draws on the national guidance as well as guidance from national bodies like the National Institute of Mental Health for England. So this is an evidence-based and practice-based evidence tool or model. It's underpinned by ideas that have worked already. And as Colin and Sasha have said, the thread of it being co-produced all the way through means that it's got a strongly preventative arm. So in a nutshell, in summary, the funding requested is going to be spent to skill up our staff to make sure that we all understand what we need to. Personality disorder represents about 30% of a community caseload, between 50 to 75% of an acute caseload, and yet mental health nurses currently doing a 3-year degree are given an afternoon on personality disorder in 3 years. So there is a really significant gap in understanding in our workforce and our service users. So our training program is designed to meet the need that gap presents, as well as provide people with these specialist therapeutic skills to deliver interventions from secondary mental health right the way through to primary healthcare.
Thank you. Eugene, do you want to say more?
So, Justin, thank you very much, Lulu. Thank you, Christopher. So, in summary, the board is asked to sign off and agree that the business case that's across East and West Suffolk, just to finally add to what Lulu and Carl and Sasha have said so far, this is obviously a local priority for us as identified in our needs assessment and in our 10-year strategy 18 months ago, and a national priority. So what these guys have done is trailblazed personality disorder, and the national agenda has now caught up with funding to be able to support the very thing that we're trying to do. So we're seeking agreement. Thank you, Christopher.
Thank you. Members of the board, I'm sure you all wish to endorse that strongly and give your agreement to the business case as provided, which you will have read and which we explored last week also. Thank you very much.
Thank you.
You're going on, Eugene, to item.
Yeah, I'll go back to the mental health agenda. Lulu, Carl, and Sasha, you're very welcome to stay with us or to go off and enjoy your days as we get into the other parts of the mental health conversation this morning. Thank you for
your meeting.
Thanks, Eugene.
I really appreciate your consideration with the time as well. Thank you very much. Thank you.
Thank you all.
Thank you. Bye-bye. Bye-bye. Thank you.
So just in terms of our mental health investment plans for the CCG, the paper that's part of the pack today confirms that we met our mental health investment standard for 2020-21 as audited by NHS England, and we've submitted plans to NHS England for 21-22 to ensure that we do the same again. And again, the paper that's in your pack sets out our areas of investment across our programme of work for the coming year and beyond. We've also been fortunate to receive transformation funding to prime a number of the things that we need to take forward, and some recovery funding. There was a 500 million pot of funding from Claire Murdoch, the National Mental Health Lead. And again, the table in your pack sets out what we have from a Suffolk and North East Essex perspective by CCG. And we're working up plans in terms of the recovery for those areas. So just by way of illustration, there's a specific pot of funding to recover our dementia diagnosis rates in terms of the fallback due to COVID, which has been a national trend. So I'd like to move on, if we may, to the eating disorders case, phase one of the case. We have Sarah Cross with us from Norfolk and Suffolk Foundation Trust to give us the headlines. Just in terms of setting the scene, we have an eating disorders service which is under significant demand. Again, this is a national trend across the country, and we were due to be bringing forward an age-inclusive eating disorders business case for consideration. I think, such as the urgency of the response that we feel is required, we have brought forward phase one of an investment plan to tackle some of the challenges which Sarah will set out in a moment, and we'll be bringing back the fuller system-wide eating disorders business case as part two by the end of June is the timetable that we're working to have that complete. So if I could ask Sarah to introduce yourself, please, to the board, and just to give us the headlines of the phase one investment. Thank you, Sarah.
Thanks, Eugene. Hi, my name is Sarah Cross. I'm the service manager and the clinical lead for the all-age eating disorder teams in Suffolk. Thanks very much for allowing me the opportunity to bring this paper this morning. As Eugene says, this is a stage one of a full programme of development, which will be part of a full business case. But the situation has very much changed over probably the last year to 6 months, certainly with COVID. We've seen a huge escalation in the numbers of both young people and adults seeking assessment and treatment for their eating disorders, including quite a significant increase in the level of acuity and risk that people are initially presenting with. We are looking to, with this paper, we're looking to be able to fund an increase in our specialist service to provide an improved workforce with both nursing, medical and psychology and dietetic input, which will allow us to work to be able to meet the current levels of need in terms of assessment and treatment, and also as a staging post to begin our medical monitoring programs, which is a national priority, and also to look at our marzipan pathways, which are underway with our local acute medical teams in both hospitals in Bury St Edmunds and in Ipswich. Hopefully everyone's had an opportunity to look at the paper, which has got a lot of detail about specific posts. But just to say a little bit about the national and local context. So from a national context, there's a significant programme of development underway in terms of offering an early intervention approach for both adults and children's. The children's intervention changes have been underway for several years, but the adults are relatively new, and we are now hoping to invest in a freed programme for 19 to 25-year-olds, which offers an early intervention for people at a very early stage of their illness or who've had an eating disorder for a short period of time. Obviously, the goal of this is to reduce the impact of eating disorders on people's life opportunities, which is, as you know, are very significant, both from a psychological point of view and from a physical well-being point of view. We also have a local context, as I said, of significant demand, which is also being experienced nationally. And current challenges are also that we, from a system-wide point of view, acute beds are under considerable pressure because accessing out of area beds has become increasingly difficult over the past year. This recovery plan is to address immediate needs with the specialist team. Okay, so what we've looked at this year is we've done some significant work looking at the trajectories this year in terms of the number of referrals that are coming through to us, and worked on two different options. One is that we do nothing, and as you can see from the charts, that will have a significant impact over a 20-month period where we will not be able to meet our current level of need, either for children or adults, which will pose a significant risk to both young people and adults within the teams. We've seen a 56% increase in referrals for children and young people between 2019 and 2020, and that increase is continuing at the current time. As many people know, we've struggled over some time to meet our KPI for children and young people in terms of the access and waiting time standard, and this trajectory shows no opportunity for us to improve upon that. Current challenges also include we have effectively come to a point where we have two historic teams that have come from two historic systems of management across Suffolk, and we're now have the opportunity to work together far more closely to develop a parity of services cross-county and to be able to move forward with developments with co-production cross-county. We're looking to be able to develop our SEEDS pathway, which is a severe and enduring eating disorder pathway for people with a more chronic illness, in partnership with local stakeholders, and for children to be able to do a scoping activity to look at ARFID presentations, which we also know are increasing regionally and nationally. The proposals that we have also put forward are for us to be able to seek an additional package of support from VCSE partners, including BEAT, Wednesday's Child and Mind. The BEAT and Wednesday's Child packages would allow us to offer an immediate package for every parent and carer that has a young person on our waiting list. That would be an intervention with BEAT, and also for every young person to receive an intervention. The goal of that would be that either they would be continued to be supported whilst waiting more specialist intervention, or for some people, particularly presenting at a very early stage of their difficulties, that may be all the intervention that is actually required. The staffing posts that we're looking to focus on, these are both to meet an immediate need and a longer term needs in terms of development. We've got significant investment going into consultant and clinical psychology posts, but also significant investment into our nursing posts. The goal of this is to be able to support the medical monitoring pathways and the local acute admissions, but also to provide a career pathway for nurses coming into the teams, because we know from experience that we're very much having to grow our own workforce, and one of the the pieces of information we've certainly received locally is that we need to be looking at a career promotion, because we know that actually at the moment, and probably for the foreseeable future, we will be up against some competition in terms of recruitment with other trusts, both relatively locally.
Thank you, Sarah. I think that gives a flavour in terms of the business case and the urgency in which I think we all agree that we need to move. If I could just ask Hannah very quickly to come in to say a little bit more about the broader business case, that the system-wide that we're expecting to bring through in June, and those relationships with the VCSE, please, Hannah.
Yeah, morning everyone. I'm Hannah. I work in Eugene's team as a mental health transformation lead, and I lead on adult eating disorders. My colleague Jamie Hawkins leads on the CYP, so the under 19 part of the service. So we've been working with Sarah and colleagues to pull together a system-wide all-age business case. So I just wanted to sort of really underline that this is an all-age offer, which includes, as Sarah's referenced, support to families and carers as well. We've been working with those VCOC partners that Sarah mentioned. Specifically for adults, we've got a proposal from Suffolk Mind, who are developing and expanding their existing recovery support that is already in place. So we're working really closely in developing those relationships. We had a system-wide workshop a couple of weeks ago with all of those partners in the room and specialist colleagues, just to really start co-producing what the future should look like. So just to sort of reassure everyone that this is, again, like with the personality disorder work, really co-produced, and we've got feedback from service users and carers as well that we're feeding into it. In terms of the business case, we're almost ready with the sort of part 2 of that to present at the end of June. We just got a few final tweaks to make to it, but that will absolutely describe that VCSE offer. So it really is a system pathway as opposed to just specialist services. Thanks, Eugene.
Thank you, Hannah. So I think it's important to look at the similarities between our approach to personality disorder in the preceding case and eating disorders. We really are trying to build a system that builds resilience and early intervention and prevention in the type of responses and interventions that we're trying to put into our system going forward. So at that point, I'll pause, Christopher, if I may, and seek approval or any questions to colleagues to Sarah. And I know Sarah Gibbs has also just joined us from an SFT.
Okay, does anybody have any questions? Looks like not. Looks like we can move straight on to approval. Are we all happy to approve this section?
Yes, thank you, Christopher.
Thank you very much. Thank you.
Thank you, Christopher. In which case, I'll move on to the final part of our mental health conversation this morning. To Sarahs, please feel free to stay or to go and enjoy your days as well. Thank you for your input this morning.
Thanks very much.
The final part this morning is supported by John Harris, who's our commissioning lead for the East of England Ambulance Service. The mental health long-term plan requires CCGs to support ambulance services in terms of their important input in terms of crisis services and promoting mental health. And what John has brought today is a regional proposal at ICS level in terms of raising awareness and supporting mental health in the ambulance service. We have money set aside for this in terms of our planning with NHS England. So without further ado, I'll pass on to John. Good morning, John.
Thanks, Eugene. Good morning, everyone. Good intro, thank you. This is a pilot scheme we're looking to trial over 12 months, and it just brings us closer in terms of those patients who are in crisis, calling the nines with a mental health professional who can get their on-scene or support crews and ensure that the patient gets a better experience, but also in terms of outcomes. There are studies elsewhere which show that you can reduce inappropriate conveyances to ED, and also at points of escalation to reduce some of the 136s that come through. So we feel that this is a kind of a toe in the water. It's a trial. As Eugene says, it's supported by the region. We have the money, and we want to see how we can integrate the nines with the mental health pathways over a longer term period, and this allows us to sort of evaluate what our options might be. So this should bring things like psychiatric liaison, the treble 1 service, all the mental health professionals we've got out in the community that respond to these patients, to hopefully bring them closer to the nines and the crises that the crews have. They're very, very challenging often, and often we get long delays. So we are really looking forward to seeing whether we can reduce some of those. As Jane said, demand is rising, and I think we've got a kind of really complex set of patients here who we need to know more about their behaviour and how we can best support them. So I really am behind this role, and I hope you can support this today.
Thank you, John. So Christopher, if we can just pause there and seek comments and then agreement. Thank you.
Thank you. You all heard about this last week as well, everybody. Are there any further questions? No, so I think we support that also. Eugene, thank you very much.
Thank you.
Thanks, Christopher. That's great news.
Thank you. Thank you. So that ends item 7. Thank you very much. Kate, do you want to do the video as part of your West Suffolk Alliance update?
Yes, that would be brilliant. I think we've all left now, but I want to say thank you for all. There's an enormous amount of work that's gone into that mental health agenda item. I think it was just such a powerful piece.
It was.
As a board to listen to. So just thank you and the team for everything, Eugene.
Yeah, thank you. Right, over to you, Kate.
Thank you very much. Simon, would you like me to do my paper and then you run the video, or the much trailed video?
No, please do your updates and we'll show the video afterwards. That'll be fantastic.
Okay, brilliant. Okay, so if I walk you through our Alliance paper, we've grouped the paper around the Alliance ambitions. So to start us off, we are talking about some of the interactions that helps people in their community to stay well and manage their own health and well-being in a more proactive way. And we have a fantastic example of vertical integration, which came out of a crisis really during COVID, but with West Suffolk FT and Abbey Croft Leisure. We started to work proactively together to understand more about what the needs are within the individual clinical pathways from a physical activity perspective, in terms of preparing people for procedures and for managing their own conditions, and from a rehabilitation perspective afterwards. And I think I'll take the section of the paper as read, but the observation would be that previously, before COVID, but before this kind of agreement and the work that we've been doing over the last 18 months with Abbey Croft, really, when I very first came into the system and was speaking to them as a provider, they found it incredibly difficult to find their place in terms of being able to target the right population to give the wraparound support that they've got some brilliantly skilled staff to do. And that's improved over the last couple of years, but this has just been a fantastic catalyst in terms of formalising that within our localities. And it's where we've had Abbey Croft Leisure's staff working with our integrated neighbourhood teams during COVID. They also have some existing relationships now that have also been able to weave into this. And the other observation would be just the impact that it's had within the hospital in terms of helping them understand, I think, more about the impact that they have on the broader system, and how the interventions that happen within Hardwick Lane also then have a sort of a before and after impact on people's lives and their families' lives. And I think they're really enjoying and rising to the challenge of what the potential therefore might be of that as a partnership. So it is a fantastic step forward, and we're starting to look more broadly about where we can go with this as a partnership. But from our board perspective, I think it absolutely underscores the kind of work that we are trying to do with our local population. I've also put a section in here around the work that's been happening, which a lot of you are very familiar with the additional roles within primary care. This has been a piece of policy which has been tricky in terms of being able to make sure that we made the most of the opportunity, which is about bringing additional workforce in to support primary care over and above the GP element of primary care, because primary care, as we know, is it covers a much broader scope of work than just that carried out by our GPs. So we've got a list there, and we've got Lois has provided us with where we've got new people in post within the system or coming into post. So I think we've got a strong coverage, and I think we've had an appetite to use those individuals to give an enhanced offer to our populations in the locality. So I'm not going to go through that in too much detail, but it's there as an update, and we'll bring something back further when we've got some case studies. Just to preempt Linda's question, case studies probably further down the line of how they've worked in practice. And I feel we've trailed it already, but the work that's going on around the vaccination and how we are supporting our communities is so phenomenal that I wanted to just recognise, as Ed alluded to, we have the broader vaccination programme, which has been very successful, very challenging, but very successful. But we've also worked within this with our community leaders and our faith leaders to understand actually what additional it is needed in terms of amended offers to get the vaccination out to the people that need it most. And there's a couple of examples and a great picture of Dan and team with the COVID bus as part of the paper, just where to give some more detail about how we've nuanced the model and work with communities to do that. And most recently, last week, we were working with the racing community and the stables to make sure that we were able to offer take the vaccine to the working population to make sure that we are able to have equity of access. And then we've talked about this previously, but we are working an ongoing piece of work around our homeless population, and just lending itself to the conversation that we just had around mental health, building in a strong element of co-production into that, and having the voices of some of our homeless population in part of the discussions around where do we go from here in terms of our offer in West Suffolk for those individuals to not just look at a temporary solution, but what they need in the longer term. And it has been a fantastic piece of multi-agency working. And we're talking at length at the moment around the white paper and where we are looking at provider collaboratives and how we will work differently going forward as a system. And actually my reflection on this is that this has taught us really that isn't necessarily just around the acute provision. It is around multiple agencies. We've got the Department of Work and Pensions, we've got the police service, we've got social care, mental health, drugs and alcohol, all in one conversation, just understanding how they can positively impact this cohort of patients of our population, but equally how that learning can then be extrapolated out to other vulnerable groups. It's a really positive piece, and when we come back with the model, we'll bring that through board. And then the final piece that I probably draw attention to is we are starting our One Team development programme, which is the extension of the One Clinical Community piece that we ran last year, which was incredibly successful. And this is working more intensively with our integrated neighbourhood teams about how they work together and how they use the resources and capacity in the broader system to support their populations within their localities. But also where we have the Future Systems work, which is the title for the work that's underway looking at the new hospital provision for West Suffolk FT. It has a new name now, but unfortunately it slipped my mind. But it is the Future System piece of work more broadly. It's the One Team absolutely is feeding into that kind of broader conversation about, as a system, what is our clinical pathway and how does that model work in terms of how we wrap around our population. And to make time for the video, I'm going to take the other pieces as read, and then I will take questions if that's okay, Christopher.
Thank you. Are we going to the video first or the questions first?
Just because I want to say it, maybe we should run VT, Simon.
Yeah, let's run the video first and we'll have the questions after, if that's all right, please.
Okay.
COVID-19 has had a devastating impact, not just on us as individuals, but also on our local economy, testing the resilience of our communities to the very limit. The response to COVID-19 saw communities spring into action and has demonstrated the importance of partnership working across the West Suffolk Alliance. Over 60 new community groups were formed in West Suffolk as a direct response to COVID-19. Community groups like Good Neighbour schemes, which are put together and run by local people and supported by our voluntary and community sector colleagues like Jane.
Over the last year, the Good Neighbour schemes have provided voluntary support to residents in their communities and those who've needed help with shopping, prescription collection and delivery, and also things like checking in and chatting with them, offering befriending and support over the phone, and also some of the schemes have been able to help with getting residents to their essential medical appointments and vaccinations through voluntary lift giving. These Good Neighbour schemes and their volunteers really care about their community members, their neighbours, and they're wonderful people that give their time to help others in their community.
Hundreds more people came forward to volunteer, from staffing vaccination centres, delivering prescriptions, helping neighbours with their shopping. Thousands of hours were given up willingly to support those who are most vulnerable in our communities. And this was on top of all of the fabulous community groups that were already active in West Suffolk. Voluntary groups just like Home Start.
I'm volunteering with Home Start because I love what they are doing with helping families and vulnerable parents who've had possible situations and struggles which have been quite difficult to overcome. It's really inspiring to see the enthusiasm and passion they have for the work that they do. I admire their views and commitment with helping others. It's completely selfless and rewarding.
The difference that Nazia and all of the volunteers have made to their communities is immeasurable and has been inspirational. Our NHS services, our local authorities and our partners in the voluntary and community sector have managed to continue providing support to the people of West Suffolk throughout this most challenging period. This partnership working can be seen in the success of the drive-through vaccination sites, which saw local businesses generously donate their buildings, car parks and equipment to support the smooth running of the mass vaccinations. GP practice volunteers, such as the Woolpit Volunteer Group, who saw 170 people come forward at the start of the pandemic, have been vital in setting up and staffing the vaccination sites. Without our communities, none of this would have been possible. The Suffolk Says Thanks campaign recognised this and built on a simple call to action to residents of all ages to share their thank you messages.
The Suffolk Says Thanks campaign started in the summer of 2020 to celebrate everyday acts of kindness and give people the opportunity to thank others and their communities for sticking to the COVID-19 guidelines. I represented West Suffolk Council in this campaign, which was a collaboration between district and county councils, different charities and organisations. We want to say a big Suffolk Says Thanks to everyone who has helped their communities and the strength and resilience everyone has shown.
Without our communities, none of this would have been possible. So from the West Suffolk Alliance, thank you.
Thank you, Simon. I think that was worth waiting for.
That's great. Thank you very much. Very heartwarming.
Can I make one point before we just take any more questions?
Yeah, we're going to go for questions.
So I think I've ended the paper with a draft graphic. I think that what is, and the video makes the point as well, what is I think so key at the moment is communications and actually the conversations that we are having. And I think our patient story kind of underscored that as well, and the way in which we are able to articulate. We talk about an alliance, but we are talking about partnership and an ability to work together, and how we communicate that out to our population is key for them to understand the support that is there for them. So as a system that we are signed up to doing that together, and we're doing a significant piece of work. The hospital are refreshing their strategy and other stakeholders are refreshing their strategy. So bringing it together and having a common message, as that kind of video encompasses, and the diagram at the end, the drawing at the end of the paper does as well, I think are going to be really key to this in terms of where we go in the next 12 to 18 months.
Thank you. Ed.
Yeah, no, thank you, Kate. Great video. And Sarah Colley's on a number of these videos. She's absolutely brilliant. I have to say, we should recognise that, what a great job she's doing. My question on the paper was the additional roles that are coming into primary care is really welcome. But is there going to be a connection between those new members of the team with the One Team programme? So just so that they get the ethos of integrated working. I wonder what your thought was.
Yes, absolutely. I think the thing with the One Team programme is being able to free up staff to attend, and I think that's and the space that are available on it. But absolutely, that is the ethos, and there's sort of broader conversations as well within the professional groups that represented in that table as well, in terms of how we make sure, kind of as a system, that the support for their development, etc., doesn't just fall to the individual practices, because I think that's the thing that makes some of the roles tricky, in terms of if you're looking at an individual practice taking on the employment and the kind of full risk associated with making sure you get the most the best level of support and the most out of the role itself. So I think the ethos has been we will try and share some of that across the piece, so that workforce is in the paper as well. But I think from a West Suffolk perspective and broader in Suffolk, we have a fantastic offer career-wise for staff within our system, and I think that tying them into those system conversations is probably one of the unique selling points of that as well.
Thank you. Andy, have you thought better of it, or? Yeah, okay, thank you. Right. In which case, I think we say thank you very much to Kate for the update, and very heartwarming and very encouraging for the way forward. And we'll move on.
I'm sorry, I've just noticed that Hayley is on the call as well, and Sarah did the voiceover, but Hayley masterminded it from the engagement team. So I just wanted to give you, not to embarrass you, Hayley, but to give you a name check as well. Thank you very much.
Thank you.
Thanks, Kate.
So we move on now to item 9, the community engagement group, patient and public involvement. Linda.
Sorry, thank you, Christopher. I just take the paper as read. You can see some of the activities that have been going on from the community engagement group, and happy to take any questions.
Thank you. Any questions for Linda? Yeah, Ed.
So it was just back to the kind of opening remarks I made about younger cohorts not necessarily coming through for vaccination, and particularly younger men. So I don't know whether there's any work we can do through your group around understanding what the issues are and what potential solutions might be.
Thank you, Ed. Yes, I think that's really important, and I think the council have their contact with the community team and with the families and community team, and I think we're linking in more closely with those, and in association with the West Suffolk Alliance engagement activities. And we've got a meeting after this, which I'm hoping that we can take that and at least ask the question as to how it might be taken forward. Thank you.
Thank you.
Kate, do you want to add?
Just only in support of what Linda said, we're also talking to West Suffolk College as well about doing that piece and a broader piece, looking at young people's experiences during the last year and actually what they need going forward. So the vaccination piece will be part of that as well.
Yeah.
Okay, thank you very much. Okay, we go on now to Paul and the procurement update.
Thank you, Christopher. So the paper is to note, and I will take the paper as read, but if I can just pull out a few things that I think are quite important. In terms of neurodevelopment children's services, we're really moving at pace now, and actually we are in a moderation process. I think this is quite an exciting piece of work. It's so much that it sort of builds on to some of the work we've almost said in terms of principles of the PD work that we heard earlier on. So very much about the social care model approach, which sort of focuses really on prevention, intervention and support, which are absolutely key. The other things to pull out around that one is, as you note, that it's a 2-year +4 contract, which is really important sustainability as we move forward. The only other thing to say about that one is clearly because we are moving at pace, we will probably need a separate part 2 before sort of July, because we want to be able to award in July. So to make the point that we are moving at pace, so usually exciting piece of work. The other element is to carry on the theme around mental health. You'll note that we are waiting for service specification to be completed. This is really quite important because this will allow us to start looking at what services are going to be provided locally and the assurance piece that follows, but equally help us to identify the gaps that we have in the system and to go out to procurement for those elements that we require support from partner organisation. So again, quite an important piece of work moving at pace. And finally, the pathology element, as you know, has been stalled for a number of reasons: COVID, national changes, etc. We're very much at the stage now where we've actually stripped down the service specifications, and we're ready to bring that through the clinical scrutiny committees, and that will need to be quickly followed by a paper that sets out the procurement process, which is the commercial procurement process, and the board will need to understand quite clearly what that actually means in practice. And finally, there are just a couple of small paragraphs which shouldn't go sort of unnoticed within the paper. The first one being that we are still waiting for national legislation changes to understand how procurement is going to change. I think in equal measure that will make it simpler and harder depending whether you're part of the health family, and we're trying to unpick the detail around some of that. We'll bring something forward as we learn more. And finally, importantly, we do meet our obligation, the Social Value Care Act, in terms of our questioning of our procurements, but we are meeting with local authority colleagues and procurement leads across the system to see whether we can do more as part of the anchor organisation piece of work. So again, as that evolves, we'll be bringing something forward as part of the procurement evolvement and understanding how we approach procurement. I'll stop there. Happy to answer any questions.
Thank you very much. Are there any questions?
I think Kate's got a hand up.
Sorry, 1 second.
Yep. No, for once I haven't got my hand up.
But Jeff has.
Hi, thank you, Christopher. Paul, I wondered where the procurement board fits into all of this work, please.
Yeah, so that's a really good question, Jeff. As you know, part of the procurement argument was that we should be bringing the whole system together. There are clearly boundary changes, conversations going at the moment, which I suspect will be imminent in terms of understanding how that's going to pan out. We simply paused, if you want, our sort of development of that. The collaboration is still happening, but we've paused because essentially we don't want to start a board if it's going to look different.
Okay, thank you.
Thank you.
Any further? Okay, thank you very much, Paul. Thank you. So now we will go on to the next item, which is Lisa on the Learning from Lives and Deaths report.
Thank you, Chair. So I am going to hand over to Wendy Scott, who has joined us just to go through the paper, but just to remind the board that the LEADER programme is the Learning from the Lives and Deaths programme, and the aim of the programme is to review the lives and deaths of people with learning disabilities who have died in Suffolk. So this is our annual report. You will see there is a wealth of learning that's come from the reviews that we've done. There's a lot of work happening. I think Wendy will give you a great overview of the work, but going forward, I think we really need to think about how we continue to integrate this work into the work of the CCG, the work that we all do every day within the CCG. This is a group of people that suffer health inequalities and have suffered health inequalities for a long time. So I know we've got really strong programmes of health inequalities, but we must make sure that we remember people with learning disabilities in that. So Wendy, thank you. I'll hand over to you.
Thank you, Lisa. So hopefully you've all had sight of the paper, which is here today for publication approval on our website. And when it is published, it will also be published in a user-friendly version. But just to go through some highlights with you, if that's okay. So Since the programme began of reviewing lives and deaths, Suffolk has continued to meet 100% trajectory on reviewing those within 6 months of notification. We've had 66 for East Suffolk and 44 for West, so 110 in total. And during this past year, which of course has been a particular challenge to everybody, we've had 42 notifications, 24 for East and 18 for West. There's analysis of the notifications, which I'm not going to go through in any great detail, but I will just say that we continue to have our death rate of this population below the national average. We see an increase in females dying during this period of time compared to males. And we have seen a decrease in people passing away in hospital. Now, again, we continue to see that 36% of deaths are associated with pneumonia, which is a theme which keeps coming out time and time again. It's a national thing for this cohort, but I think we need to acknowledge that within this. And the second leading cause of death was sepsis. Now, 57% of the reviews completed said that care was satisfactory. Now, just to give you a little bit of a brief about COVID, because it has had an impact, we received 7 related notifications during this last year, 5 for East and 2 for West. Now, we can't say for certain because we haven't seen the national report yet, but we think we've done really well in Suffolk, I have to say, and I think we should all be really quite proud of the fact there's only 2 deaths in the West, which I know you represent today. That doesn't mean to say that we couldn't have done better, but I think our social care providers have done a marvellous job at shielding and working together as a system to really support these individuals in difficult times because they don't necessarily understand the social distancing rules, and it has been a real challenge, the shielding of this population who often rely on routine as part of their everyday living, really. Now, with regards to those where lives have been reviewed, 51% were offered an annual health check and 48.5% had an annual health check. Now, we're not able to say whether that would have made a difference or not, but I feel it's important that is actually highlighted here with you today. You'll see on page 16, there is a grid of thematic learning. Our themes of learning do not differ greatly to everywhere else, and they're also not mutually exclusive to this cohort. We know that MCA is an ongoing issue, mental capacity assessment for everybody within the acute hospital trusts, and particularly with our elderly population and people with dementia included. There has been a national drive regarding do not resuscitate orders, because we weren't going through the right process to have those in place for this population. And locally, we've done a huge piece of work to try and make sure that it's completely understood. Now, we have done so much work, and I'm not going to go through it all in its entirety, but we know that really to be able to have people's physical health needs met, we need to really focus on annual health checks so that we're able to understand what people's health needs are. Our advocacy service ACE have been commissioned to work with individuals so that they understand what to expect when they're going to have an annual health check, and we've done some pre-assessment check work as well. We're beginning to look into having a physical health dynamic support register, which will look at those individuals who are at high risk due to highly complex or high risk physical health needs, or for those individuals who have not been able to have an annual health check completed, so that we're able to provide an enhanced service offer within our specialist learning disability and autism service for those specific individuals. And that's been a huge piece of transformation work, and we've just been successful in getting some additional funding from NHS England for that piece of work. And we will be expanding what I've called at the moment GP liaison nurses, but will be called health liaison and health facilitation nurses in the future, because we need to ensure that we access all of health services for this population. And actually that will double the team in size significantly. It won't just be nursing roles, there'll also be some allied health professional roles within that as well. There's been so much work around screening and ensuring that this population can go and get their cancer screening. There's been work around epilepsy and ensuring that the carers understand caring for an individual with epilepsy and looking out for the signs and symptoms. And of course, flu vaccination. So alongside the COVID vaccination was an increased incentive to GPs to deliver both at the same time, but also to deliver annual health checks at the same time. Our areas of focus in the future will be to obviously look at our implementing our action into learning across the whole system, to hone down and look at. We're very good at data in the NHS, aren't we? We love numbers and trajectories, and that's great because that offers us focus and gives us a timeline of what we need to be aiming for. But our focus in the future is going to be having a look at the quality of what we're actually delivering. What are the outcomes to the individual and what are their experiences in accessing health services, which I think is really important, and their carers as well, because most of these individuals are supported by carers, and they're telling us different stories, I have to say, which we need to take into account. We know the reasonable adjustments, we know the flagging system is all coming online, and these things all fit together, all the different parts of a jigsaw that need to be in place for this population. I think that is probably about it, really, in terms of the highlights of the report. Now, just to draw your attention to, the LEADER programme is changing in the future. A new policy was disseminated in March 21 and it's been put back a bit. We thought we had to start in September, but actually we have to implement it in its entirety by April next year, so April 2022, apart from the computerised system, which was supposed to be operational yesterday, but there were some glitches, so that hasn't quite happened yet. The significant difference is that it will be an ICS approach as opposed to a CCG. Now, I believe we've got the right people around the table already in our LD steering group. So some of this is just making sure that we're working together and continue to do. And tomorrow we've got our LD steering group where we'll be mapping out our plan and our project plan of how we're going to implement the new policy together, because it is a togetherness, not led by just us. And I think that, and the other bit just to highlight is that within, sorry, Lisa's laughing at me because there's always, with me, there's always something else I've forgotten, is that in the policy, we start working with individuals and mortality reviews who have autism. Now, that's not written in your notes. We think they might have autistic traits. That is individuals who have a diagnosis of autism. Now, there's a lot of anxiety about that, but the early reports from NHS England, where they have been able to work out how many deaths we're talking about nationally, is 300. I don't think that's accurate. I think we have a number of individuals, and the challenge for all of us at the moment is the waiting list for diagnostic services, which we've got to get better at in the long-term plan. That's 18 weeks. We're nowhere near that in Suffolk at the moment. I just need to get that in there really quickly. So they're the biggest challenges for us moving forward, but I believe we can do it as a system.
Thank you, Wendy. Can I just, sorry, Christopher, can I just quickly add before you go to questions? I think that there's something, I said it yesterday in East, I'm just going to say it again in West today. There is some very, very specific work that we need to do with Wendy's team on improving our access into services for people with learning disabilities. But there is also a real wider piece of work that we need to focus on around how we commission services and how we make sure that the services we commission are making sure that reasonable adjustments are applied, all the work with our providers. It's a real thread that needs to be in the front of everybody's mind as we work with this population group. Otherwise, Wendy working on her own with her team, we're never going to see the true transformation for this group of people that we need to see. Thank you.
Thank you very much. Ed.
Yeah, thanks, Wendy. I'm sure people appreciate this, but Wendy is viewed as an absolute leader in this field in the region, and I think is annoying other systems being told, do it like Wendy does it. So thank you, Wendy, for all of your leadership and all of your team. You're absolutely one of our stars. My question was around the BAME element of this, and in your cover report, you're saying about the reporting from BAME families, BAME communities, maybe not where it needs to be, or we may not have the right understanding of those that community. And I just wanted you to say a bit more about what we're doing to address that.
Yeah, so at the moment, on our LD GP registers, we have 3,156 people on our GP registers, but we don't know how many of those individuals are also part of our BAME community. So that's a piece of work we need to unpick and understand, because until we unpick and understand that, are we going to know actually, or have we got under-reporting for those individuals with regards to their deaths? Now, we don't think we have, because even someone brought it up yesterday, it's not within the policy that they have to be reported, but we've got a really good system in Suffolk, I have to say, and everyone is, I mean, GPs, the acute hospital trust are all really keen that we do report on these deaths. But we still need to unpick that information, Ned, because it's not just about this Lead Our programme that would have an impact on. It's also about, it's almost a double whammy, isn't it, of health inequalities that we really need to address. So for us, we're trying to unpick that at the moment. It's not easy trying to work out that.
Thank you.
Thank you. Linda.
Thank you, Christopher. And perhaps just going on from that, I notice in the paper it talks about that the CCG paid for some bank workers to carry out some of the or parts of the LD annual health checks. And I'm just wondering if that's going to continue, or you know, how will that be taken forward to make sure the numbers are going up or in the right direction?
Yeah, thank you, Linda. So in the new policy that's been published, there are certainly implications for the workforce that we need to have in place to be able to deliver the Lead Our programme. And at the moment, Suffolk has 2 bank workers which work part-time for us to deliver that. Now, we're having some conversations which Lisa has been part of, because we're concerned whether that's sustainable in the long term. So if one of them decided not to do it, if someone was on but we also don't have the economy of scale to necessarily employ someone ourselves. Now, we're very fortunate with regard to this programme in terms of we are part of the regional network. So we are part of the regional learning disability autism board, and we're not alone in those conversations. So there is a regional conversation taking place around those reviews. And actually, is there an opportunity for us to work together to be able to deliver those, to ensure that there is a standard as well that's actually within part of those reviews? That's really early conversations at the moment, Linda, but I'm happy to come back and expand upon that once we've got some more concrete information.
Thank you.
It's on our radar to worry about.
Okay, thank you, Paul.
Yeah, thanks, Lisa. Just I was reflecting what you said yesterday, and as you know, we do undertake equality impact assessment with all procurement and service specification, etc. But I wonder whether, you know, Wendy could work with our team really to see how we might strengthen that framework, so we ask the right question at the right stages of the procurement process. So happy to take that away if we can, to put Jane and Wendy together and have that conversation.
That'd be really helpful, Paul. Thank you.
Thank you.
Thank you. Any further? Okay, well, thank you very much. Thank you, most helpful. Now, finance, performance. Thank you, Wendy. Bye-bye.
Thank you, everybody. Bye-bye.
Finance, performance and scrutiny. Jane, looks like you're going first.
Yes, thank you, Chair. So in your packs, you have apologies, quite a long paper, which is around the planning that we've been doing as a CCG and with the wider system for the first half of the financial year that we've just moved into. So I'll assume that people have read the context of the paper. We are planning for a half year for majority of things, apart from mental health, which obviously we've discussed some of that earlier on the agenda, where we have received the resourcing for the full year. So there are various bits to this paper. The planning process we've been through has involved and is still involving multiple different submissions around our activity, our finances, our workforce, and what we've included in the paper is the latest draft of those. Final tweaks of those are being made for a further submission later this week. So what I propose we do, if that's okay, Chair, is if we go through each section just very briefly. I won't go into every line and number, but just to give the kind of summary position on each, and I'll bring in colleagues who are leading on the particular areas, if that's okay.
Thank you.
So the first part of the plan is the plan narrative. Now that effectively that we have We have had a template from NHS England to complete on that, and we've done a very thorough assessment, which is basically looking at how are we as a system and as our CCGs delivering on long-term planning targets as they sit in the context of post-COVID recovery. Now, Richard's completed this section of the paper, and what we haven't done at this stage is to bring the narrative, firstly because it's a very long document, but secondly because it effectively needs to be finished when everything else is there, because it kind of is the summary of the whole picture. So what's been suggested is that we bring that back to the governing body in due course once it is completed for information. It does follow a very standard format, and we are still picking up the NHSE comments on there, but you can see in the paper we've got the a summary of the sections that includes. It's basically a wide-ranging overall summary of the plan. So I wasn't going to say any more on that, if that's okay. Just quickly pause if there are any questions. If not, moving on, the next section is around activity and performance, and I'll just hand over to Paul at this point to introduce.
Yeah, thanks, Jane. I think that the only point to make is around how activity is been constructed. So if you will recollect, when we were having the conversation around phase 3, we were set some very clear targets around activity. 90% of elective activity needed to be reached, 100% of diagnostics, and equally for outpatients appointment. A similar approach has been taken nationally, with the exception that it's no longer activity driven, it is value driven. In other words, it's 70% of baseline value of 1920. So that's the first important point. The aspirations within the plan has been quite prescriptive in the sense that we are expected to be at 70% in April, rising by about 5% every month up until 85%. I have to say these are sort of planning guidance and other system. We are planning to go much further than that, which is an important point. The importance of the thresholds essentially is that there is an ERF, which is an elective recovery fund, and essentially the system will be reimbursed over and above that threshold to the value of about tariff plus 20%. Which is a recognition that actually it's probably going to cost more to do more activity. So again, there is an income that will be coming to the system over and above meeting those thresholds. So again, that's a huge difference from what was previously in place in the phase 3 conversation. But finally, just to reassure, there are also a number of gateways that we are meant to be achieving. And broadly, they are surrounding workforce, i.e. the way we look after our workforce, which is an important point. How we manage and look at the health inequalities is another gateways. How we focus on outpatient transformation. How we focus on productivity elements. So there's about 5 gateways that we will be submitting on a regular basis to our regional colleagues as a demonstration that we are doing all the right things and achieving the result all in a right way. Finally, to some degree, this conversation has been superseded by the accelerated site conversation. And if it's all right with folks, I'll pick that up as part of the performance report, because actually it has some direct implication and narrative around the RPR performance report. So I think that's all I need to say around that element of it.
So, Chair, shall I just wait to see if there are any questions on activity? I don't see any immediate ones, but obviously there'll be an opportunity for any questions at the end. So moving on, the next section is the workforce plan, and I'll bring in Amanda.
Thank you very much, Jane. So the key points from the workforce plan is that I think we're very fortunate in West Suffolk to have a very mature workforce alliance approach to all things people, actually, and they have been meeting regularly for quite a long time now under Kate's leadership, and I think they've done tremendous work, quite frankly. And of late they are focusing on 3 key main objectives which are in the paper, and I think they are the right objectives, and I think the other alliances could take a lead actually and follow suit. But in essence, the work from the West Suffolk Alliance Workforce Group is then fed into the wider system workforce group, which is called the SNE People Board, and vice versa. And Kate is a member of the People Board. And I think it's fair to say that the People Board, we've met 3 times now, and we're gaining stronger traction with our system leaders as we move forward. I think that is progress and in the right direction. We have got an ambitious workforce programme, And the main theme underlying everything is around focusing on the one workforce approach. And that is where we have, a focus on not just health, but wider partners, including care and the voluntary sector, as well as the district and borough councils. And also another ambition of our workforce programme is to really reinforce the good practice and principles of being an anchor organisation, and we feed into the system anchor board and demonstrate and showcase how we're actually supporting that agenda through the health and care academies and our apprenticeship programme. And the last point I wanted to draw out was the close relationship that we're developing through the Integrated Care Academy. And as we move forward and deliver our workforce programme, that is going to be a significant key partner and one that we will be wanting to grow over the coming months. So I'll leave it there, but very happy to take any questions. Thank you, Jane.
Thank you. Any questions on that section? No, on you go, Jane.
Okay, I'll carry on. Sorry, it's a bit of a tour de force, this paper. So the next section is the resilience plan, which you'll see includes the draft resilience plan that we submitted in there. There's a summary in the paper. I don't know if you wanted to add anything, Paul.
On mute for the first time. Apologies. No, except to say that it's quite an important element really of the overall plan. It's so much that you can't just look at the recovery without looking at in terms of how you manage your emergency services in particular. And clearly there are sort of predictions, and we don't quite know when, that there might be another COVID surge. So again, this is really an amalgamation of all the learning, all the work that we've currently undertaken from a COVID resilience point of view. And the only other thing to say, which I don't think quite comes out in the paper at the moment, is the fact that we have maintained our tactical readiness in terms of review and ready to move quickly in terms should there be any additional COVID surges or any difficulties within the system. So again, I'll take the paper as read, but it's pretty self-explanatory in terms of the things we're looking at.
Thank you.
Okay, so carrying on, I'm going to finish with the last but not least finance plan, if that's okay. We'll just cover the other bits of the paper first. So section 8 is the cancer plan submission. What you'll see is it's basically alerting the governing body that as part of the overall Suffolk and North East Essex plans that we submitted, we did submit overall ICS performance and plans around areas of cancer which has a particular focus. So you've got a summary in there around the cancer programme overall, and obviously as part of the IPR papers we do monitor in detail what's going on with cancer. So I wasn't going to say any more about that particular section unless there were any questions.
Nope, looks like not.
And the final one before we come back to the budget and the finance plan is mental health investment plan. Now, obviously, you've seen this. It should be the same information as was in the original plan presented by Eugene. In contrast to the rest of the financial budgets, we have thankfully been given that full year funding and the commitment around the mental health investment standard for the full year. So this is just presenting the financial plans around those, but it's effectively that reflection of those various different investments that we, some of which we saw earlier and others we've seen at other times at governing body. So I'll pause on the mental health investment plan before I go back to the budget.
No, I think no questions there. I think we've done mental health investment this morning already, so.
We have, and apologies that it was a bit repetitive. So as a governing body, we have to sign off the CCG's budget for the year. And so the paper in Annex or Appendix D is effectively a repeat of a paper that we took to our Financial Performance Committee last week, which looked at the overall resources available for the system and then into the CCG. So I'm not going to go through each of those slides in detail, but to give you a summary of the system position. So the 3 CCGs have received allocations for the first half of the year, for the full year for mental health resources, and the background slide really picks out the main elements of that. I've spoken before about a sort of a hybrid situation that we're in, whereby we have resources as a CCG and we can make decisions about allocating those, but a lot of those decisions are made for us. So you'll see in the paper that there's continuation of the centrally calculated block contracts for our main providers and the prescribed uplifts for those. So effectively, we have very little discretionary resource within the CCG's allocation. And of that discretionary resource, the uplifts that have been given are centrally prescribed. You'll see that in the paper there are tables setting out the prescribed uplifts for example, prescribing and CHC, which are our main discretionary expenditure areas. Paul's already spoken about the elective recovery fund. That is a new element for the first half of the year that we're in, where this is about incentivising the system and providers to deliver activity levels above that baseline that's set out in the paper. And obviously our work as an accelerator site will have a big impact on that, but we're doing lots of work around calculating what payment might be available for that extra activity to our providers. The other separate sources of funding over and above this, the key CCG allocations are a continuation but slight scaling down of the hospital discharge programme. That's the fund that assists with admission avoidance and hospital discharge through the COVID period. That continues, but as I say, in a slightly reduced format and with capped budgets for areas into the first half of the year. We also have a number of areas of service development funding, and we've obviously spoken about those in detail, particularly as they come in through mental health. So the various different slides take you through all those assumptions and the system position. The CCGs as a collective across Suffolk and North East Essex did receive an amount of COVID funding, 48 million for the continuation of the work that we put in place in the last half of last financial year. You'll see the tables show that effectively we allocate that in line with expenditure, the majority of which takes place as you would expect in our partner trust organisations. There's also a table in the plan around the growth funding. Again, that was about 17 million across the system. That was allocated on a rollover basis via the 3 alliances, and that's included in the paper. So the summary of the system is that the draft plans that we put in for all the organisations within our overall control total submitted balanced positions. There were significant amounts of efficiencies required within those plans to achieve that balanced position, and a number of risks cited in there, which for the purpose of planning, each organisation has said that there are mitigations in place, but obviously there will be a lot of work to do to ensure that those efficiencies and mitigations are achieved. So moving into the CCG, specifically, there's a set of slides again that were looked at in detail at the Finance Performance Committee, and what you'll see is that because of the sort of interplay of the relatively low uplifts that the CCG was given and the prescribed nature of the block contracts, the finances for the CCG will be extremely tight. I'm going to pause because I can see that Ed's got his hand up. Did you want to come in, Ed?
Yeah, thank you, Jane. On the funding for the discharge programme, there was a new policy that was issued on Friday, which is maybe later than we would have hoped for. But does that affect the financial plan in any way, or do you think we've got a good plan in place?
So there was guidance was issued on Friday, which we were waiting for. I think when we had the Finance Performance Committee, we said it was in draft. We had actually seen an earlier draft of it, and the final guidance is not significantly different. The funding envelope that we've been issued as a system is lower than we claimed in the relative parts of the previous year, but we are in discussion with because this fund picks up both CHC costs from the CCGs and costs from our partners in the council. So we're in discussion with the council about those, but we believe that it should be deliverable within the envelope. We've still got to finalise that, but effectively we knew what that envelope was going to be when we pulled the plan together, and we flagged it as a risk, but we've not put it down as an issue that will stop us from breaking even.
Thank you.
So thank you, Ed. Continuing on into the CCG plan, you'll see that I'll just take you through the headlines. We have submitted a balanced plan for the first half, this dreadful term H1 of 2021 that we're all getting slightly used to at the moment. It incorporates the first 6 months of the mental health plan that we've been through separately. And it includes re-establishing a small COVID fund and continuation of the growth funding from the previous part of the year. In achieving that break-even position, you'll see from the allocation that we received and the pressures that we've had to deal with that, we've not been able to re-establish a CCG contingency reserve. Now, that was something that was requested of the CCGs. and we did attempt to do that, but in line with other CCGs, both within our STP, ICS, and across the region, there's no additional funding to create that contingency, so it's not that surprising that we've not been able to. Now, this was discussed in detail at the Financial Performance Committee, and obviously it's not a position that we would want to be in as a CCG, and we did talk about the need to push forward on efficiency programmes, to clarify all other funding sources and other areas of funding that we might use within the patch, but we will need to keep a really close eye on all of those, given that we don't have a contingency in the budget for this part of the year. So maybe I'm sure that will come up under the questions. But you can see in there the main reason that we have a pressure is that effectively the additional funding the CCGs were given is insufficient to cover all of the inflation and growth uplifts, and it's approximately £1 million short. So we've had to use any flexibility that we've got to cover that before we could put in a contingency reserve. It's worth pointing out that the plan doesn't include the costs of Agenda for Change, but we are expecting those to be separately funded, at least for our trust colleagues, if not necessarily for CCG staff, because that element has not been confirmed. So the slides go on to give you the plan summary, building from the forecast outturn from last year, and showing how the various different funding streams come in and out. It's been quite complicated to unpick a lot of that because of the financial regime last year, but Chris took the Finance Committee through that last week, so I'm not going to go through that in detail unless people have got any questions. The pack contains a list of those adjustments and also the risks and mitigations in the plan. As we said, that achievement of efficiency is key, so we flagged that as a risk. We also believe there are some risks around non-NHS provider sustainability as we move forward, particularly as people are continuing to work in that post-COVID world and their costs have increased. There are some potential risks to CCG finances around that, as well as the independent sector activity, which is coming back into our budget. And as it's been sort of pulled back centrally in the last half of, in the whole of last financial year. So we're assessing that there may be some risks associated with reinstating that. So the final two numerical slides show the application of the CCG growth. You'll see that it's quite a complicated table, but basically one of the main pressures that we're needing to deal with is around CHC, where the funding uplift that we received inflation-wise is 0.2%. But obviously we work in conjunction with our colleagues in social care, and because of their timing of their budgets and their decisions, which were a lot earlier than we received our allocations in the CCGs, there have been some decisions made around inflationary uplifts which are significantly higher than the 0.2% that we've received. So County Council have offered 4% to the majority of providers. Some of that we have to match because we're in joint contracts, and others we are looking at how we can what we can offer as a CCG. However, we've included the cost of that 4% uplift, which is one of the main pressures that in the budget. There's also a range of other things in there. You'll see things like the NHS Think 111 that we spoke about in detail at the executive and governing body. The central funding for that ceases, and so it needs to be picked up, as is the same with the, trying to find it on the list, but it's the I've forgotten the name of it now, but the diabetic self-testing. It will come to me. Apologies for that. I'll find it on the list. But so there's a number of things that we've needed to pick up as a CCG within the budget, as well as those enhanced inflationary uplifts. But final slide is the breakdown of the budgets overall, because as a governing body we need to approve the budgets, formally approve the budget. So we've just given you an overall breakdown of how that will fit into the different categories within the CCG. So in terms of the next steps, the system plan is under review by NHS England at the moment, and any final changes are being made as we speak. We don't anticipate any significant changes to the CCG budgets. There might be a few tweaks around the edges. Some of our provider partners are doing more work, particularly around the elective recovery fund, and so we'll change their submission. as I've said earlier, due to the lack of contingency and the tightness of the budget, we need to continue to look for further opportunities for headroom, and that will be around re-establishing the efficiency programme, utilising any carried forward funding and funds, that making sure that we're careful about the allocation of funds that we've got sitting with our system partners. So I'll pause there before we move to the recommendations, Chair, see if there are any questions.
Thank you. No, it looks like everybody's understood fully and is happy with what's been said so far. So on you go to the recommendations, please.
Yeah, thank you. So in terms of the budget specifically, I'm asking the governing body to approve the plan and the budget subject to any further changes in guidance or allocations. And if there are any further changes, to delegate that on to the Financial Performance Committee. I'm not anticipating there being significant amounts. It's just the timing of the governing bodies obviously are quite spaced out.
Are we happy to approve? Yeah, everybody approves. Thank you very much. Thank you.
And thank you. And for the remainder of the paper, it's written in there that if the governing body are happy to approve the draft plan documents as they currently stand, and note that there are various items that will come back, including the overall narrative, in due course.
Thank you. Right, thank you. I think you get a rest now, don't you? Because in the main integrated performance report you go at the end, Jane. So thank you. Right, so move on to item 13, which is the integrated performance report. And we're going to start with the Director of Performance Improvement, but Richard's not here, is he? Are you taking that, Paul, for him? Or Ed, you have a point?
Well, I just wondered whether we just have a quick break before we get into the report.
Okay. I was going to try and push you to 11:15 and take the break. If everybody's that desperate now, I'm happy to stop, and we'll see you all at 10 past.
Can I just remind everyone that the recording will continue, so make sure you're on mute and take your cameras off.
Okay, so we'll start promptly at 10 past. Thank you.
Jeff, do you want to take your camera off?
Hi, Jeff.
How are you, Steve?
Fine, thanks.
Good. It went well, did it?
As far as we know. I'm
Yeah, that's fine.
Can I
Good.
just tell you that you're still being recorded?
Yeah, I know,
I
don't worry.
just want to remind you that. Yeah.
Yeah, I'm not going to go deeply into my medical issues.
Would you all like to come back now, please? Welcome back. I think again. Right, relieved, refreshed, and invigorated. Let us begin the integrated performance report. However, I'm still not the wiser as to who's going to do performance improvement.
So, Christopher, I'll kick us off. As you know, Eugene is here to deputise for Richard. So, in terms of the transformational programmes, I'm sure it can be, and I'll certainly point in a couple of directions. I'm sure Eugene will want to respond to a couple of bits. Thank you. So, again, the obvious point is this is month 12 report, and the world has moved significantly since month 12. You've only got to look at the number of COVID patients we have in our hospitals at the moment, which was reported as 0 yesterday, compared to the position in March, where we still got a number of services clearly affected by the COVID pandemic, to a point where our activity, our inpatient activity, was even down to about 36%. So again, a very different world, I think, in terms of the context of the report. So, but quickly, taking sort of the main element of the report, sort of read, you'll see there are some sort of minor improvement around cancer services, the inter-performance. I think the other point to say, based on the conversation we just had around the planning guidance, organisation have locked into agreed trajectory of recovery. So again, we'll be monitoring that as we go forward. So again, clearly some ongoing focus on cancer services and trajectories. You'll see, though, that our RTT, both in terms of 18 weeks and 52 weeks, are marginally worsening at that point in time. But sort of speeding forward, really, I think it's worth pointing out that we are currently sort of in terms of activity in the upper 90s across the various pods. So in terms of inpatient activity, in terms of day case activity, in terms of outpatients and follow-ups, our activity has really ramped up quite significantly. The slight warning, and I'll come to that in a second, there is a sustainability issue, which I'll touch base on in a second. Then I draw you back to the phase 3 conversation we were having previously, is that when we opened up capacity, what we started to see was an improvement in our RTT, an improvement in our 52 weeks, an improvement in our long waiters. But what we were seeing at the time was a continued increase in our waiting list sizes, which was clearly a concern. So again, that sort of neatly takes us to the fact that we've been successful, we've been selected as an accelerated site. And so what does that mean? Essentially, I think in part it's a recognition that as a system we have demonstrated in the past in terms of our achievement and our progress and our delivery, if you want, in terms of recovery, I think played a really important part in us being selected. But importantly, I think there'll be a huge increased focus moving into the second half of the year, particularly for all systems, to say, what can you do? Can you work faster and harder in terms of recovering our elective and our performance? The accelerated site status brings a number of opportunities with it. In part, funding, which it's important to state cannot be spent on activity. It has to be about essentially transformation. So in that sense, it gives us an opportunity to really think about accelerated our digital program, our workforce programs, looking at short-term productivity. So again, also additional capacity, particularly around the use of things like Vanguard, altering sort of facilities in a day case unit at West Suffolk, altering facilities to more ward-based, and also increasingly working with our private sector. So again, it gives us the opportunity to start exploring other opportunities. Additionally, it also attracts some national support in the sense that there are a number of experts nationally in terms of programs, whether that be primary care involvement, outpatient management, elective sort of productivity, and outpatient transformation are all support which is available to the system really in a very open way and easily available and accessible.
Could I just ask who us is in terms of being an accelerated site? Is it
the system?
The West Suffolk Hospital?
The SNE system as a whole.
SNE system, thank you.
Okay, apologies, yes. So the slight health warnings within all of this is as you know, Chair, that there are some remedial work happening in theatres in West Suffolk, which essentially means that we will be losing 40 to 50% of our elective activity for about a 4-month period where that actually happens, which is in part why our aspiration as a system very much sets at 100% by July, moving to 120% in sort of September, October, because essentially was until that remedial work takes place, then actually it will be almost an impossibility as a system to hit 120%, and that was accepted nationally in terms of our bid moving forward, and therefore being recognised as we go forward. So again, really important piece of work in terms of recovery, our elective performance, etc. Already, we are seeing a number of really positive outcomes. First of all, diagnostics, so that is system-wide, is pretty much down to 7 weeks. Okay, you'll remember in terms of waiting time, we were significantly above that, and a number of other systems are struggling significantly. Thankfully, we're one of those. So again, our focus on diagnostics has been maintained through the pandemic, and our effort as we move forward. We are starting to see small reduction in waiting list sizes already, but our focus now is also on long waiters, i.e. patients are above 104 weeks and above 78 weeks are clearly our main focus as we move forward. And we are seeing some slight improvement already in that area. So essentially, that really is it's a bit of a summary in terms of the sort of constitutional target, if that makes sense. As we move through the paper, I sort of like to draw your attention to the fact that over the last couple of months there's been a significant focus on mental health performance, and I would characterise it by describing the health and wellbeing hub, which I'm sure Lisa will want to come in terms of the work that's been happening there. We've heard today the business case on eating disorder, which very much came out of that conversation in terms of focus on how we can improve sort of a performance along that basis. And the other element which we've been focusing on, which is in development at the moment, is around adult attention deficit disorder, which is another area of concern around waiting lists. Notwithstanding the wider mental health transformational program, which I'm using is quite eloquently described previously, and also touched on earlier on in the meeting. I think the other areas that I would draw your attention to, which is essentially at the end of the report, is a real, what I would call a real detailed stock take of where we are in terms of transformational programs, and we've called those the charters. But I think the reason why this is important is because fundamentally this really underpins the recovery and the performance elements. So when you look at the detail of the elements within that plan, it really picks up a number of the key issues we routinely discuss in terms of performance. So very much this is a refocus on what are the transformational plans, what are our focus, how does that fit into the accelerated program, program, and how do we really focus on recovery. So I'll stop there, bring in some of my colleagues, happy to try and answer any questions you may have.
Ed.
Yeah, thanks, Paul, for the great work you're doing and helping us to secure that national accelerator status, which is brilliant for us all. My question is specifically on ophthalmology, which I think was reported recently in the Health Service Journal as being the highest waiting times in the country at West Suffolk. So could you describe what's being done to address that particular issue?
Yeah, so a number of things, really, Ed. Thank you very much. I think there is a real inequity of service delivery across SNE. So if you look at the differential waiting times between West and sort of Ipswich East and North East, it's about a year difference. Which is really significant inequities. So we're doing a number of things. We've certainly been relooking at our day case unit efficiencies within West Suffolk itself, and Helen Beck has been working really hard on developing that element of the plan. We are securing additional capacity through New Medica. And again, that will roughly give us about 200 patients a month, which will help us to try and address some of the long tail in terms of waiting list. And there is ongoing work between SNEFT and West Suffolk in terms of sharing waiting lists, particularly around the cataracts. So when we start talking about collaboration work, ophthalmology is one of those areas which has been identified by two organisations where there can be mutual support to try and address the waiting list size. So again, I think we are relatively confident that we have some plans in place to address the ophthalmology issue. Clearly, what we need to work through now is how quickly that will address the issue.
Thank you. All right, where do we want to go next?
I'm happy to go next, Christopher, if that's okay. So I was just going to focus on two areas, but happy to take any questions on the quality section of the report. So firstly, West Suffolk, nothing hugely to escalate to the board. I know if the Director of Nursing from West Suffolk, if we asked her what keeps her awake at night, it's the ongoing management of infection control and making sure that they keep very rigid infection control and prevention practices. But I think their performance, actually, they have no COVID patients at the moment and they haven't had any outbreaks for a while. So I don't really share that worry, although we obviously need to make sure that we continue to oversee and continue that improvement. From a maternity point of view, you'll know that we've discussed that previously, that the team feels like it's going from strength to strength. They had a recent unannounced CQC visit. We haven't seen the report as yet, but the verbal feedback at the end of the day was positive, and the West Suffolk team have 3 continuity of carer teams in place in the West, and they are just collating some evidence and patient feedback around the benefits of those teams on both experience and the journeys that the women and families go along, and also outcomes for women and babies, which we are really keen to see. So nothing hugely. We're working with West Suffolk's quality team, just making sure that the process of clinical oversight for those on the waiting lists is robust. We have had one serious incident on the cancer pathway, which has kind of triggered a bit of a review for us. We've also recently, in the last week, undertaken a quality visit to look at their pathways for people with learning disabilities and complex care. So we'll be able to report that back once we have agreed the report and the action plan with West Suffolk. The area that I probably, as Paul mentioned, really want to bring to the board's attention is our CYP services in NSFT. It's probably the one area that concerns me the most in across Suffolk and in West Suffolk. So, as you know, we had the business case earlier for eating disorders. That is a concern. We've seen a significant increase in referrals to eating disorder services and sadly some presentations to the acute trusts in young people where they have maybe not received the services early enough in their illness and has led to a more significant illness requiring tier 4 admission. So really pleased that we've got the recovery plan now for eating disorders, but that was an area that I would have raised with you. The other area that I have concerns about that we're working with NSFT on is the emotional wellbeing hub. So again, they have seen some significant increase in referrals to the wellbeing hub, both self-referrals from children and young people and referrals from professionals. I think when you look at their referral rate, 50% of referrals to the hub come from primary care. Their waiting lists have increased significantly. We currently have around 2,000 children on those waiting lists. The majority of them are in so they are RAG rated as to the urgency of the response required from services. It may not be specialist mental health services, as we know, although NSFT oversee and run the wellbeing hub. They do not, the children and young people do not necessarily need specialist mental health services, but we have RED, who are children that require a response within 4 hours. We have AMBER, which are children that require a response in up to 72 hours. And then we have our green children who require a response within a month. And currently the children on the green list there are approximately 1,700 to 1,800 children, and they are waiting months for a response and to be accessed into a service. There is a harm oversight process that we are just working through in our weekly wellbeing hub meeting to ensure that it's robust and protects children and young people from harm. With that number on the waiting list, it's incredibly difficult to be able to operate a really robust clinical oversight process. So we have a weekly meeting that is looking on the demand and capacity, working with referrers to be able to identify services that may be able to receive initial referrals, so to prevent people going onto the hub waiting list. For example, school nursing. We know that some of the children and young people that are within the green waiting list could have accessed school nursing and health visiting services straight away. So we're looking at how we can reduce demand, and we've also built some capacity within the team. So in the short term, we have a collective response from NSFT, from CCG colleagues and from Suffolk County Council to increase staffing in the wellbeing hub. The ability to significantly reduce the numbers waiting has been impacted by making sure they have the right internet access and access into systems and the right training to be able to safely refer children on to other pathways and make sure the assessment is robust. So we haven't seen a huge impact on the list so far. We have just agreed a number of schemes, some of which will support increasing in capacity through the voluntary sector within the hub. Some will offer additional support again within the voluntary sector to people waiting on the list, and some of the schemes were to increase the staffing resource within the hub. But that's probably the biggest quality risk that I would raise to the board. Thank you.
Thank you.
Christopher, I can pick up the strategy. Sorry, Ed, you go first.
Ed's got a question.
No, it was less of a question, more of an observation. I was just thinking about Sasha's point about she wasn't ill enough to be cared for, and it feels that there's lots of children on the waiting list that could say the same. It's just really a very, very uncomfortable, unacceptable situation.
Thank you. Eugene.
Thank you, Christopher. Just in terms of the Strategy and Transformation Directorate, as Paul mentioned, the team have refreshed for 21-22 the programme of work across mental health and LD, CYP, integrated care, and those themes that cross over the Suffolk and North East Essex boundary in terms of diabetes, cancer, respiratory, for example. I think it's fair to say that all of those projects have been refreshed very much in the response to the recovery and the last 12 months and getting services back on track. Through conversations with NHS England and our local conversations and focus on inequalities, that is another, I think, thread that goes through all of our projects and all of our work. So all of our officers are now very much thinking about addressing inequalities in terms of the projects that they're supporting. I'd also wish to just make the board aware that we are not only trying to work much more closely across our CCG offices in terms of regular MDTs that brings together quality and contracts and transformation and all of our support services to ensure that we're working and using our time and effort as best as we can and agreeing priorities across the CCG offices, but also in terms of working at place. And I think this is an evolving piece into West Suffolk and Ipswich and East and North East Essex. So you'll see in the charters we're trying to identify where perhaps in the past we might have worked in a more of a siloed way looking at mental health. We're trying to look at where that joins up with the work with Kate and her team and the alliance partners, so the PCN mental health practitioners, the development of our mental health community model and how it joins up with our integrated neighbourhood teams and building those local relationships is very much the live discussion that we're having now and going forward. So exciting times in terms of ensuring that we've got one programme of work that everyone understands what the key projects are and how they join up. I'll leave it there. Thank you.
Kate, you have a question?
Just to add to what Eugene said, and thank you for that, Eugene. What we're trying to do from our perspective with Narinda and team and Sandy and team, because we are one team, go through the significant number of charters that we have and almost put them into the buckets around the ambitions that are largely the same for East and West Alliance, to understand how that translates into business as usual. Because I think if you stood with a community nurse or a GP, we've got several of them on this call, it's too much, but it's all stuff that we have to do, and it is evidence based. So it's brokering that and doing that translation piece, which is incredibly worthwhile. But we're sort of in the middle of doing at the moment. But the outputs of that, I think, should help us to understand, going back to the inequality piece, our gaps a little bit better, and then our prioritisation of activity probably can be informed by these in a way that we've not done before. So I think that is really positive.
Thank you. Right, that seems that bit. So
finance.
Yeah, finance. I think we've got to, haven't we?
Yeah.
Yeah, finance then. Yeah, Kate, do you want more integration or not? No, you don't.
No, let's have some more of Jane.
Okay, more Jane. Okay.
It'll be a very short bit of Jane. So included in the pack is the report for the financial year that ended on the 31st of March. So it's the full financial year, and you'll see for the short summary reports that we have reported for the CCG a break-even position. So that's an improvement on the plan that we submitted for the second half of the year, which showed a 2.9 million deficit. Included in the pack is detail a breakdown of the variances across the areas, and also a summary of the COVID expenditure which is embedded within that. So overall there's 15.7 million of COVID expenditure, so that's on top of what we would see as our kind of normal ongoing expenditure. The largest elements of that were 6.8 million, which was passed on to West Suffolk Hospital in terms of their NHS block top-up, and the hospital discharge programme at about 4.4 million, which we referred to earlier under the budget paper as continuing for this year, but albeit with new rules. So we're obviously in the audit process now, because for the full financial year we produce our full annual report and accounts. The auditors are completing their work over the next week or so, and we will be bringing the audited version back to the governing body in due course. So happy to just see if there are any questions, Chair.
Thank you. Any questions? Okay, thank you very much. I think that then takes us to the end of the integrated performance report. So we'll move on to item 14, the governing body assurance framework. Amanda has had to leave early and has deputed Jeff to lead us in the topics which are ascribed to her.
Thank you, Chair. Taking the GBAF, the government assurance framework first, I'll take the report as read. It's been through various iterations through the JLT, clinical scrutiny, audit committee, etc. And the paper identifies any changes from the previous risk ratings. So if there are any questions, I'm sure director colleagues will be able to help out there. Otherwise, I'd ask the governing body to review and approve the report, please.
Thank you. With your audit hat on, you're happy with the changes therein, are you?
I am, yes.
Thank you. Any questions and comments from anybody else? Thank you. Okay. On we go.
Taking the remuneration committee's terms of reference. This has been through the remuneration committee. This is a really response back from NHE, who have commented on our terms of reference. They've made one or two tweaks. They're identified in red, and the main change is about the remuneration committee can advise and recommend rather than approve. But with those changes identified, I'd ask the governing body to approve the amendment and the terms of reference, please.
Yes, everybody. Thank you. Thank you. On we go.
Moving on. Where are we next? Health and Safety Risk Committee. Again, I take the report as read. It's very short. A few items of note. Otherwise, I'd ask the governing body to note the paper, please.
Thank you. Questions? There are none. On we go.
Declarations of interest. Again, the paper identifies the process for declaring interests and the dates when different declarations should be made. So it's really a governing body taking assurance from the process. I think there is a number of item areas, a couple of pages where there's a number of red items, and maybe the governing body needs to think whether there's more we can do to get response from those GP practices. Otherwise, I'd ask the committee to note the report.
Thank you.
And finally, I think it's the minutes of the previous meetings, which again, there are various minutes attached. A number of the items within those we've already discussed or covered off. So I'd ask the governing body to endorse those minutes, some of which have yet to be confirmed by the individual committees. Thank you.
Yeah, thank you very much. Right. The next meeting is on Wednesday, the 28th of July. I guess it'll be Teams. I don't know. I should think it will. And then we have questions from the public. Now we have one from a Dr. Joe Pejak, and I think, Kate, you're going to respond to this because I think you've already responded to this in a different context. So he says, I have a question relating to the CCG's priorities and its work in delivering even better healthcare through more integrated services with its local partners for benefit of those living in the area served by the CCG. The question has relevance to the treatment of patients affected by health issues ranging from asthma to cardiovascular disease and lung cancer. The Health and Social Care Secretary, Matt Hancock, has said that, quotes, air pollution is a health issue. It harms the health of the nation. For each of us, our health is unavoidably shaped by the environment we live in. Environmental factors determine around 30% of our healthy life expectancy. Air pollution poses the single greatest environmental threat to human health. Breathing dirty air is associated with a host of health problems, from asthma to cardiovascular disease and lung cancer, and all too often it is the most vulnerable, children, older people, and those from poorer backgrounds, who are hit hardest. In short, clean air helps you live longer, close quotes. Given the above, what evidence and data does the CCG have in relation to the negative impact of air pollution on members of our local communities in terms of treatment of patients by GP surgeries whose health has been affected by the poor quality of air and air pollution, and subsequent referrals to hospital for treatment or further investigation? And then question 2, in addition, what action is the CCG undertaking to address these risks through its focus on integrated working, education, and development of resources locally? I think we could have a whole day on that, couldn't we? But Kate, have you got an answer which will address those points?
It's not, as you wouldn't be surprised to hear, it's not a definitive answer, but I think it's a really welcome question. So we now have, as an ICS, a sustainability lead, a chap called Andrew Urquhart, who started with us a couple of months ago. And part of my conversations with him and the challenge that he's taken on is to look at that data piece down kind of to locality level. So we just have more of an understanding of the problem that we're dealing with. And I think there are pockets of excellence in terms of the work that's going on. We have a hospital that's very committed to a zero carbon footprint, and the new build is underpinned by, from a facilities perspective, working out how we achieve that and sharing the intelligence from that piece of work. And we have Jill Corwin, who's one of the directors in our District Borough Council for West Suffolk, who leads from a Suffolk footprint on the sustainability and the environmental piece as well. So we're lucky that we have her based within our West Suffolk footprint. So I suppose the commitment from us as a CCG board is to pull these pieces of work together to understand a bit more. But I think it and what our current interventions are, but how that kind of equates to what the gap is in between that and the size of the challenge. So my suggestion, Christopher, would be that we bring something back, possibly as a dedicated report. But I would say that probably would be 4, if not 5 months away, just to give Andrew the time to pull the pieces of the jigsaw together comprehensively. But it's in terms of the topic and in terms of very detailed, reasoned argument behind the question, I think it is a conversation that we do need to make sure is on the board's radar.
Thank you very much. I think that's a great idea, and we'll look forward to that. Paul?
The only thing I would add, and I totally agree with Kate in terms of bringing it all together, but there are clearly a number of things that we are doing which actually reduces our carbon footprint. So if you look at our review of our pathways, for example, and you look at our outpatient transformational program, which is about non-face-to-face, which is actually about advice and guidance, which essentially reduces the traffic to a hospital site in terms of transport, that in itself reduces our carbon footprint. So I think there are a number of things that we are currently doing that you could look at it through the lens of reduction carbon footprint that we may not necessarily have articulated, but actually we could bring it all together and actually have quite a definitive answer to that question.
Thank you.
Absolutely. Just in addition to that, I think that's why Andrew is it was a fascinating conversation with Andrew, because even when we look at our prescribing and our use of inhalers and that kind of broader piece, stuff that you wouldn't necessarily consider the impact of face value, that there's a significant amount of research around what a difference it makes that small changes can make. So absolutely, Paul, it's bringing all of those threads together.
Thank you very much. And then we have a question from a Victoria Ladbrook, who, based on services for the menopause. She asks, question 3, well, counting from the early questions, that is, what is the CCG doing to improve menopause care in our area and access to testosterone for women, an important female hormone? Question 4, why does the CCG not support the prescribing of testosterone for menopausal women, as it is cheap, safe and effective therapy which relieves distressing menopausal symptoms and is recommended by both NICE and the British Menopause Society? And question 5, will the CCG be taking up the opportunity of the free medical training course Confidence in the Menopause from the Menopause Charity available to every GP practice in the area? I will defer to Zora, who does work in this area, but in a minute, when I've given some facts. I think that there is a relatively new menopause clinic available at the West Suffolk Hospital. I'm not sure that the CCG can necessarily take credit for that, but it is there, it is available, and it does take cases that can't be fully managed in primary care. Why does the CCG not support the prescribing of testosterone? Well, testosterone is not a mainstream medication, certainly not for women, and in primary care, there is considerable hesitancy in prescribing it for men because we have recourse to secondary care supervision. And in fact, the NICE guidelines say that where it is considered a possibility for women because of reduced libido as part of the menopause, then referral to secondary care should be considered. It doesn't say you should jump in and prescribe it. And in fact, there is no licensed preparation for females either. So everything that one might prescribe is off license. And then it says, will the CCG be taking up the opportunity of the free medical training course Confidence in the Menopause from the Menopause Charity? The first thing to say on that is that there is a women's training day, a women's health training afternoon as our CCG shutdown in September, delivered by Red Whale. That, of course, will not be all about menopause, but it will be in there. The second thing to say is that those practices or GPs who use 14 Fish, the website, as their appraisal development vehicle, will already know about that course because it is available free to one GP per practice and at £135 to any other GPs who wish to take it up. So whether that needs any further pushing from the CCG, I think if it does, we could certainly mention it on the Red Whale Day, as long as Red Whale didn't see them as an unreasonable competitor. Zora and Victoria, do you want to add anything to that?
Well, from my point of view, Christopher, I think you've answered everything as thoroughly. You've covered everything that I would have answered in terms of the menopause clinic.
Sorry, I leave you anything. Sorry.
Can you hear me all right?
Yes, yes.
Yeah. In terms of the menopause clinic and testosterone, being prescribed in certain circumstances for it's specifically in the BNF for low libido, rather than just general menopausal symptoms with specialist input, and obviously without being licensed for women at the moment. So I think you've covered everything that I was going to cover, and we are learning. We are, I will agree that GPs have had a lack of knowledge about this in the past, perhaps, and are getting better.
Thank you. Victoria, do you want to add anything?
Yeah, just on the last point from Zora, really, I think it is about training and learning. I think all GPs are open to it, and really interesting to hear actually about the menopause charity. So I think that's worth looking into further, but it is something that we are all learning more about. And as Zora said, traditionally, perhaps we haven't always known as much as we needed to, and it is an educational priority for us.
Thank you. Andy?
I just wanted to just say that the British Menopause Society, which is a society for particularly focused on the menopause for professionals, has been running for some time now and offers excellent educational opportunities, many of which are free. And they have an annual symposium, which is remote this year and actually starts next week and runs until August. And the great advantage with this symposium and society is that it's cutting edge. So the presentations are absolutely up to date and offer the latest guidance. Thank you.
Thank you. In which case, Kate, would you mind asking Lois when she's back if she would circulate that information to all practices, perhaps at her meeting next Monday or whenever, because I think that they would like to know that.
Brilliant. I will do. Thank you.
Thank you very much.
Sorry, Christopher, could
yes.
I just quickly add?
Yes.
I think the other issue is that it is about sort of women coming forward as well. And since the Davina McCall programme, which was only 10 days ago or a week ago, I've had, and I don't do very much clinical work, but I've had loads of women ringing up about menopausal symptoms, and I've prescribed all of them some sort of HRT, and that is due to them ringing and making contact with the surgery. And we as primary care health professionals wouldn't have known that they were experiencing symptoms because they haven't come forward before.
Thank you very much. Okay, that concludes the meeting. We now have a part 2. Shall we reconvene at 12? Does that suit everybody? Yeah, on the